Welcome back to the deep dive. Today, we're taking a scalpel to something we all rely on every single day, but, rarely stop to really examine the human frame.
Hmm.
We are pulling apart the complex biological machinery that builds, maintains, and repairs our skeleton, the musculoskeletal system, or MSK. And then we'll apply that foundational science to the remarkably complex architecture of the upper limb.
Yeah, and it's a crucial mission, I think, because to truly understand why a bone breaks in a certain way or why a nerve injury causes a specific kind of paralysis, you can't just memorize anatomical names. It doesn't quite cut it.
Right.
You really have to understand the cellular and chemical engine powering the whole system, the biomedicine of it all.
Absolutely. So the goal today is to provide you, the listener, with a clear, thorough understanding of both that biomedical foundation, how cells and hormones interact, and then the resulting anatomical structure. And we'll use specific highlighted facts that really reveal the genius of the system.
It really is like the ultimate
Yeah.
self-dissection, isn't it? We
Yeah.
just take our bones and muscles for granted. They just hold us up.
Yeah.
But when you actually look under the hood, the sheer complexity is just, well, astonishing. It's a constant dynamic construction project happening inside us
Yeah.
all the time. How much do we really know about those microscopic cells and chemical signals holding us together and allowing us to do things like, type or throw a ball?
Yeah.
So let's start today by diving right into that engine room.
Okay, sounds good. Let's unpack this. We'll begin with part one. The biomedical engine. This is where, like you said, the magic happens, the constant renewal, dealing with bone creation, destruction, and the really tight hormonal controls that govern everything. All right, so the first thing our sources really distill is the cellular construction crew. And it sounds like a constant, highly regulated battle of opposing forces. We've got this famous duo that really defines skeletal metabolism: osteoclasts versus osteoblasts.
Exactly. Think of bone not as some static scaffolding, but more like a perpetually updated city. The osteoclasts. They're the demolition and recycling team.
Okay.
They are responsible for resorbing old or damaged bone, actively breaking it down.
Hmm.
And then conversely, the osteoblasts are the building crew. They handle bone depositions, laying down new matrix.
Okay. Demolition and construction. And this brings up a pretty fundamental question about the bone itself, doesn't it? If these osteoclasts are responsible for breaking down literally the densest, hardest material in the body, fortified with calcium hydroxyapatite, what kind of powerful enzyme must they be using to actually digest that structure? It must require a serious chemical attack.
Oh, it certainly does. They utilize things like lysosomal enzymes, and they create these localized acidic environments right on the bone surface to dissolve that mineralized tissue. It's quite aggressive.
Wow.
And, beyond that core duo, we have other key players, too. There are the osteoprogenitor cells. You could call them the originals or the pros. These are essentially the stem cells. They hang around, ready to differentiate into osteoblasts whenever they're needed, especially during growth or, say, fracture repair.
Got it. Stem cells ready to build.
Yeah. And then there are the osteocytes. Now, these are basically mature, you could almost say retired osteoblasts.
Okay.
They've finished their main building work, and now they're actually embedded within the hardened bone matrix they created.
Right. I liked the analogy from the sources. They're described as having lost their sight.
Exactly. They no longer build actively, but they take on this crucial role as maintenance cells. They sense mechanical stress, they sense strain on the bone, and they help direct the ongoing remodeling cycle from sort of deep within the bone tissue itself. They're like little sensors.
Fascinating. Okay, so from those microscopic cells, let's zoom out a bit to the macroscopic structure. We generally categorize bone into two main tissue types, right? Compact, or cortical bone, and spongy, which is also called trabecular bone.
That's right. Compact bone is that hard, dense outer layer. It's what gives the bone its main structural strength and rigidity.
Hmm.
But what's truly fascinating as you look closer is its organization. It's not just a solid block.
No.
No, it's arranged in these highly sophisticated cylindrical units. They're called osteons, or sometimes Haversian systems.
Osteons, okay.
And each osteon is built from these concentric layers, like rings in a tree. They're called lamellae. And they surround a central canal, the Haversian canal, which contains essential blood vessels and nerves. That's the bone's internal circulatory and communication network.
Wow, okay, so it's got its own plumbing and wiring built right in.
Pretty much. And then connecting these networks, running sort of perpendicular to the osteons, are the Volkmann's canals. They link the Haversian canals together
Yeah.
and also connect to the blood supply on the surface.
And that surface is wrapped in something important too, the periosteum.
The periosteum. It's a membrane wrapping the entire compact bone. It has a tough outer fibrous layer for protection, and then a really crucial inner osteogenic layer. That inner layer is packed with those osteoprogenitor cells and osteoblasts, absolutely vital for both growth in width and for fracture healing.
Got it. Okay, so that's the dense outer shell. Then we shift inward to the spongy bone. This sounds, well, spongier, less dense.
It is less dense, yeah. It's characterized by this network of delicate bony projections called trabeculae. Looks a bit like a lattice or honeycomb.
Okay.
But what makes them really brilliant from an engineering standpoint is that they're not just randomly placed. They're specifically laid down along the lines of compressive and tensile stresses that the bone typically experiences.
So they're reinforcing it exactly where it needs it most.
Precisely. It maximizes strength right where the forces are greatest while minimizing the overall weight of the bone. It's incredibly efficient design.
That is clever. So what's in the spaces between these trabeculae?
That's where the bone marrow resides. You have red bone marrow, which is the hemopoietic tissue that's the factory site for all red blood cell production, white blood cells, platelets too.
The blood factory.
Yep. And then you have yellow bone marrow, which is mostly fat or adipose tissue. It primarily acts as energy storage, fills the medullary cavity, that central hollow part of long bones. But interestingly, in times of severe need, like chronic blood loss, yellow marrow can actually convert back to red marrow to boost blood cell production.
Wow, adaptable too. Okay, so if the materials are the cells and the final product is this complex structure, how do we actually get from, say, a cluster of stem cells to a fully formed bone like a femur? Our sources detail two really different yet equally necessary ways this happens, routes of ossification.
That's right. First, we have what you could call the direct route, which is intramembranous ossification.
Intramembranous, okay.
This process is characterized by the direct deposition of bone tissue without using a pre-existing cartilage model as a scaffold. It just builds bone directly.
And which bones use this direct route?
This forms the flat bones of the face, most of the cranial bones protecting your brain, and also part of the clavicles, the collarbones.
Okay, so walk us through the steps. It sounds like it might be a faster, maybe more streamlined process compared to building the whole skeleton piece by piece.
In some ways, yes. It starts with mesenchymal cells. Those are embryonic connective tissue cells clustering together in the area where the bone will form. They then differentiate directly into osteoprogenitor cells and then almost immediately into active osteoblasts, so it's a quick transition.
Right.
These new osteoblasts start secreting osteoid, which is basically the unmineralized bone matrix, primarily made of collagen fibers. Think of it as the soft framework.
Okay, the scaffolding.
Kind of. And then this osteoid tissue is rapidly mineralized when cells, calcium salts are deposited, which hardens it into bone. This process forms the initial spongy bone trabeculae, and eventually the surrounding compact bone and periosteum develop as well.
It still seems a little counterintuitive, doesn't it, that some of the most visible and seemingly robust bones, like those in the skull, they just skip the whole cartilage model stage. Why might they need this direct route?
That's a great question. It might highlight a need for rapid formation, perhaps, maybe to protect critical structures like the brain very early in development, get the protective casing built quickly.
That makes sense. Okay, so that's the direct route. What's the other more common process?
The second, and actually the way most of our skeleton forms, is endochondral ossification. You can think of this as the cartilage replacement route.
Endochondral. Chondral meaning cartilage.
Exactly. This is the pathway for almost all the other bones, particularly the long bones like the humerus in your arm or the femur in your leg, but also vertebrae, ribs, base of the skull.
So this process does involve that intermediary step, the cartilage scaffold.
Precisely. It starts similarly with mesenchyme cells differentiating, but this time they become chondroblasts.
Chondroblasts. Okay, cartilage builders.
Yep. These chondroblasts secrete a hyaline cartilage matrix, forming a complete miniature cartilage model of the future bone. It looks like the bone, but it's made of cartilage.
Like a blueprint.
A flexible blueprint, yeah. Then things get more complex. Blood vessels invade this cartilage model, bringing in osteoprogenitor cells. A primary ossification center develops, usually deep within the shaft or diaphysis of the bone. Here, the cartilage starts to break down and is replaced by actual bone tissue laid down by osteoblasts.
Okay, so the replacement starts in the middle.
Right. And then later, usually after birth, secondary ossification centers appear in the ends of the bone, the epiphyses. The same process happens there. Cartilage is replaced by bone. but some cartilage remains at the joint surfaces and, crucially, between the diaphysis and epiphysis.
And that remaining bit of cartilage is key for growth, isn't it?
Absolutely. That band of cartilage between the shaft and the ends is the epiphyseal plate, often called the growth plate. This is the engine behind how our bones actually increase in length throughout childhood and adolescence.
So how does that plate work?
Well, the epiphyseal plate is quite organized. It has different zones. There's a zone where cartilage cells are resting, then a zone where they're rapidly dividing, proliferating, pushing the epiphysis away from the diaphysis.
Making it longer.
Exactly. Then there's a zone where the cells get bigger, hypertrophy, then they die off, and finally a zone where the cartilage matrix calcifies and is replaced by bone tissue laid down by osteoblasts coming up from the diaphysis side. So bone chases cartilage, effectively lengthening the bone.
And this whole growth machinery eventually stops, right? The plate closes.
It does. Typically happens sometime between the ages of about 18 and 25. The cartilage proliferation slows down and eventually stops, and the entire plate gets replaced by bone, leaving just a faint line, the epiphyseal line, visible on X-rays in adults. Growth in length is over.
And our sources had a great highlight fact here about what triggers this final shutdown.
Yes, a really key hormonal signal. Estrogen is the primary hormone responsible for causing the final, irreversible closure of the epiphyseal plate in both males and females in early adulthood.
Estrogen. Interesting. So that powerful biological signal is what determines when we stop growing taller.
Fundamentally, yes.
Okay, so while length is governed by that epiphyseal plate, what about getting wider? How do bones grow in width?
Widthwise growth, or appositional growth, happens differently. It occurs primarily at the bone surface under that inner layer of the periosteum we talked about.
Right, the osteogenic layer.
Exactly. Osteoblasts, they're lay down new bone matrix on the outer surface, forming new circumferential lamellae, effectively adding layers like adding rings to a tree trunk, making the bone wider and stronger.
Okay.
And interestingly, while that's happening on the outside, osteoclasts on the inside, lining the medullary cavity, are often simultaneously resorbing a bit of bone
Why would they do that?
to enlarge the marrow cavity as the bone grows wider. This ensures the bone increases in diameter and strength without becoming excessively heavy or dense, and it maintains a good balance. # see bone maintenance and remodeling.
So once the bone is built, it's definitely not static, is it? It sounds like it's constantly undergoing this process called remodeling, a continuous loop that responds to stress, repairs tiny micro damage, and apparently replaces our entire skeleton roughly every 10 years.
That's about right, yeah. The rate varies, but it's a constant turnover.
Yeah.
This remodeling cycle is absolutely critical for maintaining bone health, and it follows a pretty rigorous sequence of steps.
Okay, what are the steps?
It starts at quiescence. That's just a resting phase on the bone surface. Nothing much is happening.
Okay.
Then comes resorption. This is where the osteoclasts, the demolition crew, get activated. They attach to the bone surface and create these temporary tunnels or pits by digesting the old bone matrix using those strong enzymes and acids we mentioned.
Clearing out the old stuff.
Precisely. Next is the reversal stage. This is a bit of a transition. The osteoclasts finish their job and move away, and other cells, like macrophages, come in to clean up the digested bone fragments. There's also signaling happening here to call in the builders.
Right, time for the osteoblasts.
Exactly. That leads to the formation stage. Osteoblasts migrate to the resorb site and start laying down new, unmineralized bone matrix, the osteoid, mostly collagen. They fill in the pit that the osteoclasts created.
Rebuilding.
Rebuilding. And then comes mineralization. Calcium and phosphate ions are deposited into the osteoid, hardening it into new, strong bone tissue. And once that area is fully mineralized and the osteoblasts become trapped as osteocytes, the cycle returns to quiescence, ready to start again somewhere else when needed.
It's a beautifully efficient loop: break down, clean up, build, strengthen, rest. And what drives this loop? What determines if we, say, build more bone than we destroy, or vice versa?
The huge factor, probably the most significant controllable factor, is mechanical stress. Or, conversely, the lack of it.
Exercise, basically.
Essentially, yes. Mechanical stress, especially from weight-bearing activities or muscles pulling actively on the bone during exercise, induces several positive changes. It directly stimulates osteoblasts to increase the deposition of mineral salts and collagen fibers, making the bone denser and stronger.
Okay, that makes sense. Use it or lose it. For bone, too.
Exactly. But here's a really key hormonal link that our sources highlight. Mechanical stress also seems to induce increased production of calcitonin.
Calcitonin, that's the hormone that lowers blood calcium, right? How does that help bone strength?
Because one of calcitonin's main actions is to inhibit bone resorption. It basically tells the osteoclast to stand down, to stop breaking down bone.
Ah, so exercise not only stimulates building, but also triggers a hormone that reduces demolition.
That seems to be the case. It tips the balance firmly towards bone formation and maintenance.
Wow, that's fascinating. The physical act of moving triggers a hormonal response that actively protects and strengthens the bone, which I guess leads directly to that rhetorical question our sources pose. If muscle pull directly increases bone strength, is exercise not just for muscle fitness, but is it actually fundamental to the very survival and structural integrity of the bone itself?
I think the evidence strongly suggests yes. It's Wolff's law in action. Bone adapts to the loads placed upon it. And the inverse is equally critical and unfortunately very common.
Being sedentary.
Exactly.
Huh.
A sedentary lifestyle or immobilization like being in a cast causes a breakdown in this remodeling harmony. Bone resorption starts to outstrip bone formation because there's no mechanical stimulus signaling the need for strength.
So the demolition crew keeps working, but the builders slow down.
Pretty much. This leads to demineralization, decreased collagen fiber production, and ultimately significant bone weakness, making bones more brittle and vulnerable to fractures. Astronauts experience this rapidly in zero gravity, for example.
Okay, we absolutely have to move now to this essential, well, the sources call it a tightrope walk of calcium homeostasis. We tend to think of calcium mainly with bones, but it sounds like it's the ultimate utility player, vital for almost every systemic function in the body.
Oh, it truly is. Its importance goes way beyond just bone structure. Calcium is absolutely critical for muscle contraction.
Hmm.
Think about the initiation of every single movement you make, from blinking to running.
Right.
It's essential for neurotransmitter release at the synapse, how nerves talk to each other and to muscles. It's involved in blood clotting for wound healing, maintaining the integrity of cell-tight junctions, intracellular signaling pathways, hormone release. The list goes on.
Wow. Okay, so because of all these diverse life-critical roles, the concentration of calcium in our blood plasma has to be kept within an incredibly narrow normal range, right?
Extremely narrow.
Mhm.
Any significant deviation, high or low, can cause serious problems very quickly.
So with calcium being responsible for such diverse and essential functions, how on earth does the body manage the rapid fine-tuning needed to keep those plasma concentrations just right? It must require a system that can switch really fast between pulling calcium out of storage, mainly the bones, and putting it back in.
That's precisely the challenge, and the body meets it primarily using three key hormones working together, often in opposition. Parathyroid hormone, or PTH, calcitonin, which we mentioned, and the activated form of vitamin D, which is called calcitriol.
Okay, PTH, calcitonin, and vitamin D, calcitriol.
Yeah. You can think of PTH and calcitonin as working like a direct opposing feedback loop, mostly managing the rapid exchange of calcium between the bone reservoir and the extracellular fluid, the ECF, which includes the blood plasma.
All right, let's start with PTH then. This is the hormone that kicks in when calcium levels get too low, right? Hypocalcemia. Its
Yeah.
job is to increase blood calcium.
Correct. PTH is produced by the chief cells of the tiny parathyroid glands, which are usually located on the back of the thyroid gland in the neck. Now, its mechanism for breaking down bone to release calcium is one of the most, well, maybe counterintuitive regulatory loops in the body. It needs to be understood clearly.
Okay. How does it work? Does it just tell the osteoclasts to start working?
You'd think so, but no. PTH does not directly bind to the osteoclasts, the demolition crew.
It doesn't. Then how does it cause bone breakdown?
Instead, PTH binds to receptors on the osteoblasts, the building crew.
Wait, the signal to destroy bone comes through the builders? That seems backwards.
It does seem backwards, but that's how it works.
Yeah.
When PTH binds to osteoblasts, it signals them to do two things. One, it temporarily inhibits their bone-building activity. Two, and more importantly, it causes them to produce and display a protein on their surface called rank ligand, or RANKL.
Rinko.
Okay,
Yeah.
now the osteoclasts, or their precursors, do have receptors for RANKL. When RANKL binds to the rank receptor on osteoclasts, it's like flipping a switch. It strongly stimulates their differentiation, survival, and activity. They become highly active and massively increase the breakdown of mineralized bone, that hydroxyapatite, releasing both calcium and phosphate into the bloodstream.
Wow. Okay, that is complex. It's an indirect hormone-mediated signal relayed from the builders to the destroyers, ultimately triggered by low blood calcium. What about PTH's actions outside the bone? Does it do anything else?
Oh yes, absolutely crucial effects elsewhere, particularly in the kidney.
Okay.
In the kidney tubules, PTH works to increase the reabsorption of calcium, pulling it back from the fluid that would become urine, thus preventing calcium loss.
Conserving calcium.
Exactly. It also simultaneously increases the excretion of phosphate in the urine. This is important because if both calcium and phosphate levels rise too much in the blood together, they could start forming unwanted calcium phosphate crystals in soft tissues. So PTH gets rid of the excess phosphate.
Clever balancing act.
And finally, a really critical role in the kidney. PTH stimulates the final activation step of vitamin D. Vitamin D isn't fully active until it undergoes a final conversion in the kidney, and PTH is the trigger for that enzyme.
Ah, linking PTH and vitamin D together. Okay, so that's PTH raising calcium. Now for the counterbalance, calcitonin. This one acts when calcium is too high, right? Hypercalcemia.
Correct. Calcitonin is produced by different cells, the parafollicular cells or C cells, which are located within the thyroid gland itself. It's released in response to high blood calcium levels. Its main role is relatively simple compared to PTH.
What does it do?
Its primary job is to reduce blood calcium levels, mainly by directly inhibiting osteoclast activity. It binds to receptors on the osteoclasts and essentially tells the demolition crew to stop working immediately.
Puts the brakes on bone breakdown.
Exactly. This decreases bone resorption, meaning less calcium is released from the bone into the blood. Its effect is generally considered weaker and perhaps less critical for minute-to-minute regulation in humans compared to PTH, but it definitely plays a role, especially perhaps after meals high in calcium.
Okay. And the third player, vitamin D, or calcitriol in its active form, where does it fit in?
Vitamin D is essential for maintaining adequate calcium levels overall, but its primary mechanism is different from PTH and calcitonin, which mainly shuffle calcium in and out of bone. Vitamin D's main job is to boost calcium absorption from the diet.
From the gut.
Yes. Activated vitamin D, calcitriol, strongly increases the efficiency of calcium and phosphate absorption from the small intestine. Without enough vitamin D, you can't effectively absorb the calcium you eat, no matter how much you consume.
So it's crucial for getting calcium into the body in the first place.
Absolutely. It also has other effects. It works synergistically with PTH to increase osteoclast action, again, releasing calcium from bone, which seems counterintuitive, but helps maintain overall levels. And it also increases calcium and phosphate reabsorption in the kidney, similar to PTH.
And you mentioned it needs PTH for that final activation step in the kidney.
Yes, that's a key point, showing how tightly integrated these systems are.
Yeah.
You need PTH around signaling lowish calcium to fully activate vitamin D, which then goes on to help raise calcium levels, primarily by increasing absorption from the gut. It's a complex but elegant feedback system.
Okay, wow. We've spent a good chunk of time really detailing the cellular life and the chemical regulation of bone. Now that we have a better sense of what the material is made of and how its health is maintained, let's pivot. Let's look at the map, the physical structure itself. We're going to focus specifically on the anatomy of the upper limb, but first, we need the language, right?
Yeah.
The terms we use to navigate the body.
Absolutely. Before we can talk about where anything is or how it moves, we have to establish the standard reference point, the anatomical position.
Right, the universal starting point.
Exactly. So imagine a person standing erect, facing you, eyes looking straight forward, feet together or slightly apart, and crucially, for the upper limb discussion, arms hanging relaxed at the sides with the palms turned forwards, thumbs pointing away from the body.
Palms forward. Got it. Everything is described relative to that standard pose.
Everything. From there, we use pairs of descriptive terms to navigate. We need superior, meaning toward the head end, and inferior toward the feet end.
Up and down. Okay.
Then proximal, meaning closer to the point where the limb attaches to the trunk, and distal, meaning further away from that attachment point.
Closer to the shoulder versus closer to the fingers for the arm.
Perfect example.
Mm-hmm.
And then we have anterior or ventral, meaning towards the front of the body, and posterior or dorsal, meaning towards the back.
Front and back. Okay.
We also need terms for side-to-side reference. Medial means towards the midline of the body, and lateral means away from the midline.
Towards the middle, towards the outside.
Right. And finally, terms of laterality, which are essential when you're comparing structures on different sides. Ipsilateral means on the same side of the body, like your right arm and your right leg are ipsilateral.
Okay.
And contralateral means on the opposite side, your right arm and your left leg are contralateral. These terms are basically the GPS system for anyone discussing anatomy or clinical findings.
Yeah, they provide that precise location information. And these terms are often combined, aren't they? Like you might hear about something being, say, post-remedial. What immediate picture does that give you?
Instantly, it tells you the structure or displacement is located towards the back, posterior, and towards the midline medial. It gives you a specific quadrant or direction in three-dimensional space. It's incredibly efficient language.
Okay, that makes sense. We also need terms for movement, right?
Definitely. Basic joint movements include flexion, which generally decreases the angle between two body parts, like bending your elbow,
Yeah.
and extension, which increases the angle, straightening your elbow.
Bending and straightening.
Yep. And specifically for the limbs, particularly moving them relative to the body's midline, we have abduction that's moving a limb away from the center line. Think abduct like taking away.
Okay, arm out to the side.
Right. And adduction is moving the limb towards the center line. Think add it back to the body.
Arm back down to the side. Got it.
Then for the shoulders specifically, we also talk about elevation, like shrugging your shoulders up, and depression, pulling them down. And the rotational movements of the forearm are key. Pronation is rotating the forearm so the palm faces posteriorly or downwards.
Palm down.
And supination is rotating it so the palm faces anteriorly or upwards, like you're holding a bowl of soup.
Supination. Okay, I can remember that. Hashtag tag B bones and joints of the girdle and arm.
All right, let's start our journey down the upper limb, beginning at the connection point, the pectoral girdle. The first bone we hit is the clavicle, your collarbone.
That S-shaped bone at the front.
Exactly. It's a really vital strut. Medially, towards the center, it articulates with the sternum, the breastbone. Laterally, towards the shoulder tip, it articulates with the scapula, the shoulder blade. It connects the arm to the axial skeleton.
And it's pretty clinically important too, isn't it? Because it seems quite vulnerable to breaking. Where does it typically fracture?
It is very commonly fractured, often from falls onto the shoulder or an outstretched hand. The typical break site is at the junction of the middle and lateral thirds, sort of where the S-curve changes direction.
Okay. And the sources highlighted something interesting about how it breaks, or rather how the pieces move afterwards. It's a perfect example of muscle forces acting on broken bones.
Oh, absolutely.
Yeah.
The biomechanics are quite traumatic and predictable. When the clavicle snaps at that weak point, you have different muscles pulling on the two fragments.
Right.
The powerful sternocleidomastoid muscle, which runs from the sternum and clavicle up to the skull behind the ear, attaches to the medial fragment. With the bone broken, its pull is unopposed, so it yanks that medial piece upwards.
Pulls it up towards the neck.
Yeah. Meanwhile, the entire weight of the arm, plus the pull of muscles like pectoralis major, acts on the lateral fragment. This pulls that outer piece downwards, and often a bit medially, underneath the medial fragment.
So you get one piece high, one piece low.
Exactly. The result is that characteristic deformity you see, a visible bump where the medial fragment is elevated and the entire shoulder on that side drops significantly lower than the uninjured side. It's a classic presentation.
Wow, muscles really dictate the fracture pattern. Okay, moving distally from the clavicle and scapula, we get to the humerus, the long bone of the upper arm.
That's the one. Proximally at the shoulder end, it has several key features. There's the smooth, rounded head, which fits into the glenoid cavity of the scapula to form the shoulder joint.
The ball and socket.
Precisely. Then just below the head are two bumps, the greater tuberosity laterally and the lesser tuberosity anteriorly. These are really important attachment sites for the rotator cuff muscles.
Okay.
There's the anatomical neck, which is just a slight constriction below the head. But more importantly, just distal to the tuberosities, there's a region called the surgical neck.
Surgical neck. Why that name?
Because it's a much more common site for fractures than the anatomical neck, hence surgically relevant. It's a slightly weaker area just below the bulky proximal end.
Got it. And what about the distal end, down by the elbow?
Distally, the humerus flattens out and provides two key articular surfaces for the forearm bones. There's the trochlea, which is shaped like a spool of thread, sitting medially. This articulates snugly with the ulna.
Okay, trochlea for the ulna.
And then laterally, there's the capitulum, which is more rounded, like a little head or ball. This articulates with the head of the radius.
Capitulum for the radius, okay.
And there are fossae, or depressions, above these surfaces that allow the forearm bones to move fully into flexion and extension without banging into the humerus.
Now, you mentioned the surgical neck is a common fracture site, and our sources really emphasize that humeral fractures carry significant risks of nerve damage. Why is that surgical neck fracture such a specific concern? Which nerve is at risk there?
A fracture of the surgical neck puts the axillary nerve at extremely high risk of being damaged. The nerve wraps quite closely around the humerus at that level as it goes to supply the deltoid muscle and the skin over the shoulder.
Axillary nerve at the surgical neck, okay. What if the fracture happens lower down, along the main shaft of the humerus?
If the fracture occurs mid-shaft, especially if it's a spiral fracture often caused by twisting forces. The risk shifts dramatically to the radial nerve.
The radial nerve, why?
Because the radial nerve travels in very close contact with the posterior surface of the humerus, right in that midshaft region. It lies in a shallow groove called the radial groove or spiral groove. A fracture there can easily pinch, stretch, or even sever the nerve.
Okay, so surgical neck fracture risks the axillary nerve. Mid-shaft fracture risks the radial nerve. That's a huge clinical takeaway.
Absolutely critical to remember.
And talking about the shoulder joint and the axillary nerve naturally brings us to those critical stabilizing muscles, the rotator cuff. We use the SSATS mnemonic to remember them, right?
That's the one. The rotator cuff is a group of 4 muscles and their tendons that surround the shoulder joint, blending with the joint capsule. They're crucial for providing dynamic stability to the glenohumeral joint, which is inherently quite unstable because it's so mobile. It's like a golf ball sitting on a very shallow tee.
Needs active muscle support. So SSATS stands for?
S is for supraspinatus. It sits in the fossa above the spine of the scapula and comes over the top of the humeral head.
Okay, supraspinatus, what does it do?
Its primary role is initiating abduction, lifting the arm away from the side, specifically the first 15 degrees or so of that movement.
Yeah.
It also helps stabilize the humeral head.
Got it. First 15 degrees, what's I?
I is for infraspinatus. It sits in the fossa below the spine of the scapula on the posterior side, along with teres minor T, which is just below it. The infraspinatus is primarily responsible for external rotation of the humerus rotating the arm outwards.
Okay, I and T for external rotation. That leaves S.
The final S is for subscapularis. This one sits on the anterior surface of the scapula, between the scapula and the rib cage. Its tendon comes across the front of the joint.
Okay, and its job?
Its main action is internal rotation of the humerus rotating the arm inwards. It's the primary internal rotator. So ascites, supraspinatus, adduction initiation, infraspinatus and teres minor, external rotation, subscapularis, internal rotation.
Perfect. And you mentioned the supraspinatus only initiates the first 15 degrees of abduction. What takes over after that?
After that initial push, the large, powerful deltoid muscle, which forms the rounded contour of the shoulder, becomes the prime mover for abduction, lifting the arm up higher. And the deltoid is innervated by
axillary nerve, which we just said is at risk with surgical neck fractures.
Exactly. It all ties together.
Okay, so this interplay actually gives us a pretty neat way to do a quick clinical test, doesn't it? If the supraspinatus kicks off abduction, but the deltoid, powered by the axillary nerve, takes over after 15 degrees, how can we quickly test for specific damage just to the axillary nerve?
Well, if the axillary nerve is damaged, the deltoid muscle will be weak or paralyzed. The patient might still be able to initiate abduction using their supraspinatus, getting the arm maybe 10-15 degrees away from their side. But if you ask them to lift it higher, they just won't have the power. They won't be able to continue the abduction past that initial phase because the main engine for that movement, the deltoid, is offline. That inability to lift above 15-20 degrees is a classic sign of axillary nerve problems. You might also see visible atrophy or wasting of the deltoid muscle over time. #tag see Ramen hand details.
Okay, let's move down the arm into the forearm. We have 2 bones here, the radius and the ulna. Which one is which?
In the standard anatomical position, palms forward, the radius is the lateral bone on the thumb side. The ulna is the medial bone on the pinky finger side. You can remember radius is radical, like thumbs up.
Okay. Radius lateral, ulna medial. What are the key features here, especially around the elbow joint?
The ulna is really the primary stabilizer at the elbow joint. Its proximal end has a large C-shaped notch called the trochlear notch, which grips onto the trochlea of the humerus like a wrench on a pipe.
Fitting together snugly.
Very snugly. And the prominent projection at the back of this notch is the olecranon process. That's the bony tip of your elbow that you can feel.
Right.
When you fully extend your elbow, the olecranon process slots neatly into the olecranon fossa on the back of the humerus, creating a very stable, locked position.
Okay, so the ulna is key for the hinge movement. What about the radius?
The proximal end of the radius features the radial head, which is a small disc-shaped structure. It articulates with that capitulum on the humerus we mentioned earlier.
Right, the ball-like part.
Yes, but importantly, the edge of the radial head also articulates with a notch on the side of the ulna. This is where the pivoting action happens for rotating the forearm.
Pronation and supination.
Exactly. And holding the radial head securely against the ulna during this rotation is a really important ligament called the annular ligament.
Annular ligament. Annular meaning ring-shaped.
Precisely. It forms a fibrous ring or collar that encircles the radial head and attaches to the edges of the radial notch on the ulna. It effectively holds the radius in place while allowing it to spin freely within the loop.
That's clever. But this mechanism, while allowing rotation, is also responsible for a very common injury, particularly in young children, isn't it?
Ah, yes, you're talking about annular ligament displacement, which is often called nursemaid's elbow or pulled elbow.
Maid's elbow. Why that name?
It's often caused when an adult suddenly pulls on a young child's outstretched arm, maybe lifting them up by the hands or swinging them around. In young children, the radial head is not fully developed and can be slightly smaller relative to the ligament.
Okay.
That sudden traction force can actually pull the radial head partially or completely out from under the annular ligament. It subluxates or partially dislocates. Yeah, it causes immediate pain, and the child typically holds their arm protectively, usually slightly flexed and pronated, and refuses to use it. The good news is it's usually easily reduced by a specific maneuver, often just supinating and flexing the elbow.
Good to know. Okay, moving further down, past the wrist joint, we get to the carpal bones. There are 8 of them, arranged in 2 rows. This sounds like prime mnemonic territory.
Absolutely is. 8 small, irregularly shaped bones packed tightly together, forming the wrist. We divide them into a proximal row, closer to the forearm, and a distal row, closer to the hand.
And the classic mnemonic, starting laterally, thumb side, on the proximal row and moving across, then doing the same for the distal row.
The most common one is some lovers try positions that they can't handle.
Okay, let's break that down. Proximal row first. S, L, T, P.
S is for scaphoid, L is for lunate, T is for trichotrum, and P is for pisiform, which is a small P-shaped bone sitting on top of the trichotrum. So scaphoid, lunate, trichotrum, pisiform, that's the proximal row, lateral to medial.
Got it. Now the distal row. T, T, C, H.
T is for trapezium, it's under the thumb. T is for trapezoid, next to it. C is for capitate, the largest carpal bone right in the middle. And H is for hamat, which has a distinctive hook. So trapezium, trapezoid, capitate, hamatidistal row, lateral to medial.
Some lovers try positions that they can't handle. Perfect. Okay, now, of these 8 bones, our sources single out one as being particularly vulnerable and clinically significant when fractured. Which one is that?
That would be the scaphoid. It's the most commonly fractured carpal bone, usually resulting from that classic Koch injury, a fall on an outstretched hand where you land hard on your palm.
Okay, so it breaks easily, but the vulnerability isn't just about how often it breaks, is it? There's something about its healing potential.
That's absolutely right, and this is the crucial highlight fact that every clinician needs to know about scaphoid fractures. The immediate symptom is often pain and tenderness in the anatomical snuff box.
The anatomical snuff box, that little depression on the back of the wrist at the base of the thumb.
Exactly. Tenderness there after a fall is highly suspicious for a scaphoid fracture, even if the initial x-ray looks normal. But the real reason for deep clinical concern is its blood supply.
Okay.
The artery that supplies blood to the scaphoid enters the bone primarily at its distal end, near the hand, and then travels backwards or retrograde to supply the proximal part, nearer the forearm.
Retrograde blood supply, so the blood flows from the far end back towards the near end.
Precisely. Now imagine the scaphoid fractures, often across its narrow waist in the middle. If the fracture occurs proximal to where the main blood supply enters, the proximal fragment can be completely cut off from its blood source.
Ah, no blood supply to that broken piece.
Exactly. This creates a very high risk of avascular necrosis, AVN, where that proximal fragment of bone actually dies due to lack of blood. ADN can lead to non-union of the fracture, chronic pain, arthritis. It's a serious complication. That's why suspected scaphoid fractures are often treated aggressively, sometimes with immobilization, even if the x-ray is initially negative, and require careful follow-up.
Okay, we've covered the bones and joints. Let's move from the physical structure to the communication network, the nerves, and what happens when things go wrong. The intricate wiring for the entire upper limb originates from the brachial plexus, right? A complex network of nerves starting in the neck.
That's right. The brachial plexus is formed by the ventral rami, the front branches, of spinal nerves C5, C6, C7, C8, and T1, cervical 5 down to thoracic 1. These roots emerge between the scalene muscles in the neck, and then they combine and divide in a really complex pattern, forming trunks, divisions, cords, finally giving rise to the major peripheral nerves that supply the shoulder, arm, forearm, and hand.
It looks like a complicated wiring diagram.
It really does. But understanding its basic layout is key to diagnosing nerve injuries because damage at different points in the plexus or to the specific nerves coming off it results in very predictable patterns of muscle weakness and sensory loss.
And these injuries often lead to characteristic deformities, don't they? Because some muscles are paralyzed while others are still working, pulling things out of alignment.
Exactly. It's the unopposed action of the remaining healthy muscles that often creates the classic clinical signs.
Okay, let's run through some of the major nerves and the consequences of injuring them, starting with the radial nerve. We already mentioned it's at risk with humeral shaft fractures. What does it supply, and what happens if it's damaged?
The radial nerve is a big one, originating from essentially all the roots of the plexus, C5T1. It's the primary nerve supplier to the posterior compartment of the arm and forearm, basically, the extensors. Our sources use the mnemonic beast muscles for some key ones at intervites. Brachioradialis, extensors of the wrist, fingers, and thumb. Abductor pollicis longus, supinator, and triceps brachii.
Beast muscles. Okay, so extensors mostly. What's the classic sign of radial nerve damage then?
The classic textbook sign is wrist drop,
Wrist drop. Why does that specific posture happen?
because the extensor muscles of the wrist and fingers are paralyzed. The flexor muscles on the anterior side of the forearm, which are innervated mainly by the median and ulnar nerves and are still working fine, act without any opposition from the extensors.
So the flexors just pull the hand down.
Exactly. They pull the hand and wrist into a flexed, dropped posture. The patient literally cannot lift their wrist back up against gravity, nor can they extend their fingers or thumb effectively. They lose the ability to make a thumbs up sign involving extension. There might also be sensory loss on the back of the hand.
Got it. Radial nerve injury. Wrist drop. Okay, next up, the axillary nerve, roots C5, C6. We linked it to surgical neck fractures and shoulder dislocations. What's the damage picture here?
As we discussed, the axillary nerve's main motor job is supplying the deltoid muscle, key for abduction above 15 degrees, and also the teres minor, one of the rotator cuff muscles, for external rotation.
Right.
So damage to the axillary nerve leads, most obviously, to weakness or paralysis of the deltoid. This results in deltoid atrophy, the muscle wastes away, changing the rounded contour of the shoulder and that characteristic inability to abduct the arm above about 15-20 degrees.
Can't lift the arm out to the side fully.
Correct. There's also usually a patch of sensory loss over the skin covering the deltoid muscle, sometimes called the regimental badge area.
Okay. Axillary nerve, deltoid problems, can't abduct past 15 degrees. Now, what about the median nerve? Also a big one, C5T1 roots. What does it do, and what are the signs of injury?
The median nerve runs down the center of the arm and forearm and is the primary nerve for most of the flexor muscles in the forearm and also some crucial small muscles in the hand, particularly those involved in thumb movement, the thenar muscles. Our sources use the LOF mnemonic for the intrinsic hand muscles it supplies. Lateral two lumbricals, opponens pollicis, abductor pollicis brevis, flexor pollicis brevis.
OOAF muscles, okay. Lots of flexors and the thumb. Injury here gives us two really striking deformities, right? Especially if the damage is high up, like above the elbow.
Yes, two classic signs often associated with high median nerve lesions. First is the hand of benediction.
Hand of benediction, like a pope's blessing.
Sort of. This sign is seen specifically when the patient attempts to make a fist. Because the median nerve controls the flexors for the thumb, index finger, and middle finger, those fingers can't flex properly. They remain extended or only partially flexed. However, the ring and little fingers can still flex because their deep flexors are supplied by the ulnar nerve. So you end up with the fourth and fifth fingers curled into the palm, but the first, second, and third fingers sticking out. It resembles a traditional sign of benediction. It only appears on attempting flexion.
Okay. Hand of benediction on trying to make a fist. What's the second deformity?
The second is the ape hand deformity. This is a more persistent posture of the hand at rest. It results from the paralysis of those median nerve-supplied thenar muscles, particularly the opponens pollicis, which allows us to bring our thumb across the palm to touch the fingertips opposition.
Right. That opposable thumb action.
Without that muscle working, the thumb tends to fall back in line with the other fingers, pulled by the unopposed extensor and adductor muscles. It gets stuck in adduction close to the palm and extension. The thenar eminence, the fleshy mound at the base of the thumb, also wastes away, flattening the palm. The overall appearance resembles the less opposable thumb position seen in apes.
Wow. Okay, ape hand at rest due to the Edor muscle paralysis. That's memorable. Finally, the ulnar nerve. Roots C8T1. This is the one that runs down the medial side and passes behind the medial epicondyle at the elbow, the funny bone, right?
That's the one. That tingling sensation when you bang your elbow is irritation of the ulnar nerve right where it passes through that tunnel.
So what happens if you get more serious damage to the ulnar nerve, say at the elbow or wrist?
Ulnar nerve injury results in another definitive hand deformity, the claw hand.
Claw hand, how does that look?
The ulnar nerve supplies most of the small intrinsic muscles within the hand itself, including the medial two lumbricals for the ring and little fingers, and all the interosseous muscles between the metacarpals. Now, the lumbricals and interossae normally work together to flex the metacarpophalangeal (MCP) joints, the main knuckles, and extend the interphalangeal (IP) joints, the finger joints.
Flex the knuckles, straighten the fingers.
Right. When these intrinsic muscles are paralyzed by an ulnar nerve lesion, the long finger extensor muscles, supplied by the radial nerve, act unopposed on the MCP joints of the fourth and fifth fingers especially. This causes those knuckles to hyperextend, pulling them backwards.
Okay, knuckles bent back.
But at the same time, the long finger flexor muscles, partially supplied by the median nerve, but the ulnar nerve supplies the deep flexors for the fourth and fifth, act unopposed on the IB joints, pulling the fingers into flexion, curling them up towards the palm.
So you get hyperextension at the knuckles and flexion at the finger joints.
Exactly. Particularly noticeable in the ring and little fingers, creating that characteristic curled, claw-like posture. The patient also loses the ability to abduct, spread, and adduct, bring together the fingers effectively, because the interosseous muscles do that. They can't cross their fingers, for example.
Claw hand from ulnar nerve injury. Got it. Let's quickly consider damage even higher up, right at the brachial plexus roots. What about something like Erb's palsy that affects roots C5 and C6? How does that specific nerve root damage lead to the classic waiter's tip deformity?
Erb's palsy, or Erb-Duchenne palsy, is typically caused by an injury that violently increases the angle between the neck and the shoulder, stretching or tearing those upper roots, C5, C6. This often happens during a difficult childbirth or maybe a fall onto the shoulder.
Okay, stretching the upper neck shoulder nerve.
Right. Now, C5 and C6 roots are the primary source for nerves, supplying key muscles responsible for shoulder abduction, like the supraspinatus via the suprascapular nerve and the deltoid via the axillary nerve, external rotation, like infraspinatus, also suprascapular nerve, and elbow flexion, like biceps via the musculocutaneous nerve.
So paralysis of abduction, external rotation, and elbow flexion.
Largely, yes. So what happens? The remaining unopposed muscles take over. The muscles that adduct the shoulder, like pectoralis major, latissimus dorsi, pull the arm close to the body. The muscles that internally rotate the shoulder, like subscapularis, latissimus dorsi, rotate the arm inwards. And the muscles that extend the elbow, triceps, and pronate the forearm act without the counterforce of the biceps.
So the arm gets pulled in, rotated inwards, elbow may be extended, and forearm pronated.
Exactly. The limb hangs limply by the side, adducted, internally rotated, with the elbow extended and the forearm pronated so the palm faces backwards. It looks precisely like the posture a waiter might discreetly adopt when expecting a tip, hence the waiter's tip position. It's purely due to the imbalance of muscle forces once C5-C6 innervation is lost. #B, systemic bone and growth conditions.
Okay, moving away from nerve trauma, let's briefly touch on some systemic conditions that affect the bone's biomedical engine or growth, things that aren't necessarily caused by injury. We mentioned the epiphyseal growth plate earlier. What happens with extremes of growth hormone?
Growth hormone, GH, produced by the pituitary gland, is obviously critical for normal growth. If you have excessive secretion of GH during childhood, before those epiphyseal plates have fused and closed.
Before growth and length has stopped.
Right. The body responds by dramatically accelerating linear bone growth. All the long bones just keep getting longer and longer. This leads to pituitary gigantism, where individuals can grow to be exceptionally tall, often over 7 or even 8 feet.
Wow. But what if that excess GH happens after the growth plates have already closed, say in adulthood? The bones can't get longer anymore, right?
Correct. If excess GH secretion begins or continues after the epiphyseal plates have fused, usually due to a pituitary tumor developing in adulthood, the condition is called acromegaly.
Acromegaly. Acro meaning extremities, megaly meaning enlargement.
Exactly. Since the long bones can no longer grow in length, the excess GH stimulates bone growth primarily in width and thickness. This occurs most noticeably in the bones of the skull, face, hands, and feet.
So what are the characteristic signs?
You see changes like a prominent brow ridge, frontal bossing, enlargement of the jaw, prognathism, widening of the nose, and coarsening of facial features. The hands and feet become noticeably larger and thicker, often described as spade-like hands. Soft tissues also enlarge, like the tongue and internal organs. It's a very distinct clinical picture, resulting from GH acting on bones that can only grow appositionally.
Fascinating difference based purely on timing relative to growth plate closure. Okay, what about conditions that just weaken the bone structure itself, maybe by disrupting that remodeling cycle or messing with the materials?
Well, the most common one, especially in older adults and particularly postmenopausal women, is osteoporosis.
Right, porous bones.
Essentially, yes. It's characterized by a pathological loss of overall bone mass and density. The bone quality might be normal, but there's just less of it. This happens because bone resorption, the osteoclast activity, starts to significantly outstrip bone formation, osteoblast activity.
The balance tips towards demolition.
Exactly. And this is very closely linked to declining estrogen levels, particularly after menopause in women. Estrogen normally has a protective effect, partly by restraining osteoclast activity. When estrogen drops, osteoclasts become more active, leading to net bone loss and increased fragility and fracture risk.
A major public health issue. Okay, what if the problem isn't the amount of bone, but the quality, specifically the mineralization process?
If the bone matrix, the osteoid, is laid down correctly by osteoblasts but then fails to calcify or mineralize properly, the bones remain soft and weak. In children, this condition is called rickets.
Rickets, often associated with.
Vitamin D deficiency. As we discussed, vitamin D is crucial for absorbing calcium and phosphate, the minerals needed for calcification. Without enough vitamin D, the mineralization process falters, leading to bowed legs, thickened wrists and ankles, and other skeletal deformities in growing children. The adult equivalent, where mineralization of newly formed bone matrix is inadequate, is called osteomalacia.
Soft bones due to a lack of mineral. And what about problems with the matrix itself, the collagen framework?
That brings us to osteogenesis imperfecta, sometimes known as brittle bone disease. This is actually a group of genetic disorders where there's a fundamental flaw in the synthesis or structure of type I collagen.
Collagen, the main protein in the bone matrix.
Exactly. Since collagen provides the framework that gives bone its tensile strength and resilience, defective collagen results in bones that are extremely fragile and break very easily, often with minimal trauma. The severity varies greatly depending on the specific genetic defect. #C muscle and neuromuscular breakdown. Now let's shift focus slightly from the bone itself to the interaction between nerves and muscles, the neuromuscular junction, because failures here are also critical. The ability of the nervous system to communicate with muscle is absolutely fundamental for movement, and disruptions can lead to profound weakness or paralysis. It's actually quite useful to compare two conditions that cause muscle weakness, but through very different mechanisms at the synapse.
Okay, yeah, the sources contrast myasthenia gravis and the effects of botulinum toxin. They both result in muscle weakness or paralysis, but they attack different parts of the neuromuscular transmission process.
Precisely. Let's start with myasthenia gravis. This is an autoimmune disease. The body's own immune system mistakenly produces antibodies that target and destroy the nicotinic acetylcholine receptors, NERHRs, located on the muscle cell membrane, the postsynaptic side of the neuromuscular junction.
So the immune system attacks the landing sites for the signal.
Exactly. Acetylcholine, ACDUA, is the neurotransmitter released by the motor nerve to tell the muscle to contract. In myasthenia gravis, even if ACEA is released normally, there are fewer functional receptors available for it to bind to on the muscle side.
So the signal doesn't get through effectively.
Right. The transmission becomes inefficient. This leads to muscle weakness that characteristically gets worse with repeated activity as the remaining receptors get saturated or desensitized, and improves with rest. It often affects muscles controlling the eyes and eyelids first, causing ptuitosis, droopy eyelids, and diplopia, double vision, but can affect swallowing, breathing, and limb muscles too.
Okay, autoimmune attack on the postsynaptic receptors. How does botulinum toxin differ? That's the stuff used in Botox, right? But it's also a potent toxin.
Indeed, botulinum toxin, produced by the bacterium Clostridium botulinum, works much earlier in the transmission pathway. It acts on the presynaptic nerve terminal, the nerve ending itself.
Before the signal is even sent.
Correct. Botulinum toxin specifically targets and cleaves proteins, called snare proteins, that are essential for the fusion of the synaptic vesicles, the little packets containing ACE, with the nerve cell membrane, which is necessary for releasing the ACE into the synaptic cleft.
So it physically stops the release of acetylcholine.
Exactly. It inhibits the release of AC from the motor neuron. If the signal, the ACE, is never released into the synapse, it doesn't matter how many healthy receptors are waiting on the muscle side, the muscle simply cannot be stimulated to contract. This results in flaccid paralysis.
Wow. So myasthenia destroys the receiver, botulinum blocks the transmitter. It really highlights that question. If one condition destroys the receptor site and the other stops the signal from even being released, aren't both mechanisms essentially achieving the same clinical outcome paralysis just by disrupting different critical steps in that essential nerve to muscle communication?
That's a perfect way to summarize it.
Yeah.
It underscores just how vulnerable this precise, multi-step process of neuromuscular transmission is. Any interruption along the chain leads to failure.
Okay, one last critical clinical condition we need to cover, which is a true surgical emergency. Compartment syndrome. This often happens after significant trauma, maybe to the forearm or the lower leg.
Yes, it's a limb-threatening and potentially life-threatening condition that requires rapid diagnosis and treatment. It typically occurs in anatomical compartments, areas where muscles, nerves, and blood vessels are tightly enclosed by inelastic fascia, like the compartments in the forearm or the calf.
So what triggers it? A bad fracture?
Often, yes. Severe fractures with significant bleeding and swelling inside the compartment are a common cause. Crush injuries, burns, very intense exercise in untrained individuals, or even tight casts or bandages can also trigger it. Reperfusion injury, where blood flow is restored after a period of ischemia, can also cause massive swelling.
Okay, so swelling inside a tight, unyielding space, what's the pathophysiology? What actually goes wrong?
It's basically a vicious cycle driven by rising pressure. The initial injury causes bleeding and edema, swelling within the closed fascial compartment. Because the fascia doesn't stretch, the pressure inside the compartment starts to rise rapidly. Soon, the pressure inside the compartment exceeds the pressure within the veins and lymphatic vessels, collapsing them. This prevents blood and fluid from draining out of the compartment effectively.
So fluid gets trapped, pressure rises more.
Exactly. As venous outflow is impaired, capillary pressure increases, forcing more fluid out into the tissues, worsening the edema and driving the compartment pressure even higher. Eventually, the pressure can rise so high that it exceeds arterial pressure, compressing the arteries and cutting off the oxygenated blood supply into the compartment.
Ischemia, lack of oxygen.
Right. This leads to muscle ischemia, which is incredibly painful, and also nerve ischemia, causing altered sensation like tingling or numbness, and eventually paralysis. If not treated quickly, the muscles and nerves can die, leading to permanent functional loss, contractures, and potentially requiring amputation. The dead muscle tissue can also release toxins into the bloodstream, causing kidney failure.
That sounds incredibly dangerous and fast-moving. Clinicians rely on the 6Ps to help diagnose it quickly, right? What are they?
Yes, the 6Ps are a classic mnemonic, though not all may be present, especially early on. They are.
Often described as deep, constant, poorly localized, and crucially out of proportion to the apparent injury. This is often the earliest and most reliable sign.
Pain out of proportion again.
Palpably tense compartment. The affected muscle area feels rock hard or woody to the touch due to the high pressure.
Right.
Pain with passive stretch. This is considered a hallmark sign. Gently stretching the muscles within the affected compartment causes excruciating pain. For example, passively extending the fingers would stretch the swollen flexor muscles in the forearm.
Pain on passive stretch. Got it.
Paralysis or paresis. Muscle weakness or inability to actively move the affected parts, a later sign indicating significant nerve or muscle dysfunction.
Altered sensation, like numbness, tingling, or pins and needles, indicating nerve irritation or ischemia, often happens before paralysis.
Numbness, tingling.
And finally, pulselessness. Loss of the distal pulse. For example, radial pulse at the wrist for forearm compartment syndrome. This is actually a very late and ominous sign, indicating severe arterial compromise has already occurred. You absolutely don't want to wait for this sign.
Don't wait for pulselessness. Okay. And the critical highlight fact here is the treatment, isn't it? There's only one real option.
The definitive treatment is an emergency fasciotomy. This is a surgical procedure where the surgeon makes long incisions through the skin and, crucially, through the inelastic fascia overlying the affected compartment.
Cutting open the tight covering.
Exactly. This immediately relieves the pressure within the compartment, allowing blood flow to be restored and preventing further tissue damage. Time is absolutely huge. Critical delays can lead to irreversible damage within hours. It's a true surgical emergency. #tag outro.
Wow. Okay, we have covered an incredible amount of ground today. We've completed this really detailed deep dive, journeying all the way from that microscopic cellular machinery. The osteoclasts using enzymes to break down hydroxyapatite, the intricate dance of PTH, calcitonin, and vitamin D managing calcium, all the way up to the complex leverage system of the upper limb.
Hmm.
We look at the precise mechanics behind why a clavicle fracture looks the way it does and the specific mechanism-driven clinical signs of nerve damage, like wrist drop from radial nerve injury or the waiter's tip from an Erb's palsy.
Yeah, I think the sheer interconnectedness is really the main overriding takeaway from all of this. You simply cannot separate the anatomy of a bone or a limb from its underlying biology,
Yeah.
its physiology, its cellular
It's
mechanisms.
all one system.
Completely. The ultimate strength, the health, the capacity for repair of that bone or that nerve pathway, it's governed entirely by that cellular response to all the forces acting on it, mechanical, chemical, hormonal. The machine only works because the engine underneath is constantly running, constantly adapting and optimizing.
And this whole circle of influence really brings us right back to where we started in part one, doesn't it? Thinking about movement and mechanical stress. Our sources really emphasize that exercise, that mechanical loading, induces the production of calcitonin, which actively inhibits bone resorption, helping to protect the structure.
That's right. We saw how Wolff's law dictates that bone adapts to load, getting stronger with stress and weaker without it. We saw how the remodeling cycle is driven by this. We saw how hormones respond.
So it leads to a final provocative thought, maybe. If this critical balance between building bone and breaking it down is so actively maintained and protected by the simple physical act of muscle activity pulling on the bone, does this mean that our regular physical movement is, in fact, perhaps the most fundamental, maybe even the most effective drug we have available to prevent age-related bone density loss like osteoporosis?
It certainly makes a strong case, doesn't it? It strongly suggests that the best way to maintain the structural integrity of this incredible biomedical machine that is our skeleton is, quite simply, to actively and regularly use the machine itself. Movement is medicine, perhaps quite literally for our bones.
Movement is medicine, a perfect thought to end on. Thank you so much for joining us for this deep dive into the anatomy and the biomedical engine of the musculoskeletal system. We'll catch you next time on The Deep Dive.